I welcome the PAS, the Permanent Secretary, and also Mr. Xun, and also the Permanent Secretary, would you introduce paper 1264, the answers to questions asked on the 18th of February. In our reply, we have provided information asked for by members, and that includes the thematic household survey conducted by the CNS Department in 2012 on coverage of private health insurance. The second is the actuarial models and methodology and data use, and the estimated cost of the high-risk pool, which is in Annex B. And then at the previous meeting, the chairman has also suggested that we may consider allowing insurer to offer individual-based indemnity hospital insurance plan with exclusion of specific pre-existing conditions to provide accessible and affordable health insurance coverage to those high-risk individuals aged over 40 years. Paragraphs 5 to 9. These are our replies after consideration. The whole proposal is to encourage more people to take out insurance when they are young. This is by way of balancing the public and private sector. That is also to encourage more people to buy insurance earlier, so that the risks of the risk pool will become more balanced. As for risk exclusion, between the insurers and the insured, there are quite a lot of disputes. And we can also see that the older the age, and these people who have got illnesses already, if they buy insurance, they will have greater difficulties. And if they have hypertension or diabetes, then usually the insurance companies do not want to take them on. Our proposal is that there will be a cutoff point. The age is retained at 40. Chairman, that's our response, and I'm happy to listen to your advice. Let's go over the items paragraph by paragraph. First, item A. The question was asked by Mr. Chen Kim-po. He asked, where did your data come from? Why the data were different from that of the Federation of those of the Federation in insurers? Mr. Chen, do you have any questions? Well, you give me the floor first. Oh, yes, indeed. We deal with paragraph A or Section A first. Section A or Item A. You asked him how the data came about, why the data were different from those provided by the Federation of Insurers. Yes, I comment on the paper on the 18th, on the 7th of February. 7th of April, I want to give my comment at one go. You want to do it at one go? Well, let me give my comments first. You mean Item A? Yes, the basis of the administration's data. As for Item A, now, having read the reply, you didn't know what they are addressing. I asked how many bought private insurance and went to make use of public hospital service. And there was no information. It only mentioned the major household survey. As for my question, we need to confirm the data. The data of the Federation of Insurers are different from that of the administration. The administration said those who bought private insurance and went to the public sector hospital, there are many of them. But according to the information provided by the administration, it's not adequate. We've asked the administration for further explanation. I think they have to provide us in a supplementary paper. We are given the overall survey as to those who bought insurance in the private sector but who went to use public sector hospital service. We cannot see any data here. Last time, our discussion with Mr. Chen is that of 100 people who have taken out private medical insurance, our understanding was that 54% or 54 times they went to the public sector hospitals. As for the Federation of Insurers, they said that among the claims they gave out, 90% made use of private sector hospital services. The bases were different. Mr. Chen asked us how did our figure come about. This time I explained that it was, or they were derived from the regular thematic household survey. There were a lot of detailed data, and after analysis, we came up with these numbers. Of 100 insured, we asked how many of them went to hospitals recently. Say, for example, 10 were hospitalized. We asked them whether private sector hospital, public hospital. They said, say, 5 of them said they made use of public sector hospitals. It's different from the Federation of Insurers. They looked at 100 insurance policies issued, and 90 of the insured made use of private hospital. I think the sources of data were different. The questions were different. You cannot say he is wrong, and he cannot say that you are wrong. What the question you asked is different from the question they asked, and the question they asked is different from the question you asked. 100 people come to make claims. 90 said that they made use of private sector hospitals. You accept the data? Yes, I do. He accepts your data, but he didn't ask the same question. So therefore, he doesn't dispute with you. This issue had been clarified. On this point, there was no dispute. I asked for the basis of the data. I want to know how many people did they interview, how many people bought private insurance, but how many went to public sector hospitals. I'm afraid the basis of their data was very small. Can you tell us off the cuff? They must have data behind, and they have to do some analysis. Chairman, in the first paragraph, in the last part, among those households, in the survey, a total of 13,411 households were found in a sample of 1,323 occupied residential quarters. Among those households, 10,065 households had been successfully enumerated, constituting overall response rate of 75%. Mr. Chen also asked for other data. Yesterday, we provided the data to him. The data provided yesterday weren't adequate. That was the overall survey. Among these 10,000 people, not everyone take out private insurance, medical insurance. They only asked how many took out private medical insurance, who made claims, and who went to public hospitals. You had to follow the questions. You still have follow-up data. He has to tell me what he wants, and if we have the data, then we give the data to him. Of the 10,065 households, how many have bought private insurance? Do you have the figure? Yes, I do. Among those who bought insurance, how many claimed? If they don't follow, then there will be no claims. Among those who claims, how many went to private sector hospital? We may not have the data. How many went to public hospital? No, just a minute. For those who bought, how many claimed? Those who didn't claim might have been to private hospitals or public hospitals. They might have operations. They might not have operations. They might have operations, but they might not. They didn't claim. If there was no operation, there was no claim, no use of hospitals, either private sector or public sector. How many used the service? How many claim? How many didn't claim? How many went to public hospitals? How many went to private hospitals? Well, I'll follow up. If I can have, I can provide the data. I'll provide the data.
Hello.
Item B. Do I need to allow other colleagues to speak? So, questions on the data. How many people purchased insurance? You can come back later. We can move on to item B. The average premium in Annex A, it's quite substantial. Many paragraphs. We have only one question, so I won't have a time limit. I'd like to ask Annex A, if you refer to Table 2 on page 6, it highlights the impact on HPS on average standard premium. So their estimate is, it might be minus 8% or increase of 45%, and the average is an increase of 9%. So I have a clear message here. The consultant feels that there is a range, so the government should tell people, should tell the community that it might increase to 1,500 or there'd be a slight drop. So let's say the average is 3,300, and that is the base premium. So it might increase by 1,500 up to 5,100. So you shouldn't just look at 9%. So if you can give us a range that's closer to reality. And second, I'd like to ask, if you look at Table 2, I'm surprised in Item 3, coverage of pre-existing conditions. You're aware that one of the minimum requirements is if they have pre-existing conditions, they will have to charge according to the severity of the conditions. So if you accept, then in the future you cannot deny insurance, and you cannot have extra loading because they make more claims. So this will have a large impact on the premium, and we're surprised that it only has a 5% impact. So if they could add 5% and cover this, they would have done it long ago. So it's much more than in percent, and since it's related, and when they talk about the high risk pool, please refer to Annex B and look at Item B. It says, if you are a regular person, and a person in a high risk pool will have to pay 6 times as much as a person with normal risk, and that's related to the existing conditions. So in the first annex it says just a 5% increase, but if you're talking about high risk, everybody has high risk conditions. But does it really make such a big difference? Is 600% close to reality? The industry finds it very hard to accept an increase of 5% can deal with the pre-existing conditions. So could you explain why do you think that 5% can cover pre-existing conditions? Regarding pre-existing conditions, Mr. Chan has mentioned that you have to look at that together with a high-risk pool. So if there are preconditions, there should be a loading. 100% or 200%, that would reflect the risk. So if it's reflected, there shouldn't be an increase because the premium reflects the risk. But if it's more than 2 times loading, you have already exceeded the high-risk pool. So for super high risk, you have already outside the pool. So the pool won't be affected that much. That's what it means. So you're saying that for the 6-time risks, they are already outside the high-risk pool. But when you calculate the 5%, you have already removed the high-risk pool. That's one way of putting it. But how were the figures arrived at? If what you say is correct, there should be a formula for that. It might be a bit more complex, but when you do the manpower calculations, I'll look at that later. But he's saying that your 5% figure is an underestimate. You should show us your calculations, like the DSE examinations. You can't just give us an answer. Let me add that this 5% is for people with standard risks. So you recall that includes pre-existing conditions. There are 2 ways. For new people, for people with purchase new insurance, they have a loading depending on the health conditions. If you are more than 2 times risk, they would enter the high-risk pool. Why do we have 5% here? Because a majority of Hong Kong people already have insurance, and there is a transition arrangement. And in the transition, we require the insurers, most people who purchase insurance are healthy in the beginning, but after some 10 odd years, they might have disease. So some policyholders, when they change the coverage, they might have pre-existing conditions. So you have calculations. It seems that you have not disclosed the calculation methodology to Mr. Chan. I think they're shifting the target. You're saying that in Hong Kong we won't accept people with pre-existing conditions, but you're saying that with an additional 5% you can cover these people. That is a severe underestimate. You're saying they're wrong. They haven't provided you with the formula. They haven't showed you their calculation, and now I'm asking them to show the calculations. I want to see the steps and what assumptions you have listed all out. Then we know whether you are correct. When we discussed this with the industry, they didn't highlight this. I need to object. I had met with the industry, and they have mentioned this dozens of times. They have never been able to get a satisfactory answer. I disagree with you saying that this question wasn't asked. You had just ignored them. I can provide you with the figures. he'll demonstrate the calculations. Any other questions? The next is endoscopes being done in clinics, and that is a 12% reduction. That's another surprise. Why can that reduce the premium? Do you see that? Item 6. We're very happy if you can reduce endoscopy and colonoscopy. If you do it in clinics, they will have much more cases, and if your premium doesn't include these, then why were there restrictions? You didn't foresee people doing that. Now you allow them to do these endoscopy, colonoscopy in clinics. We'll have more people taking this option, and so I want to know how you can see there's a drop of 12%. What's your response? In paragraphs 27 to 30, we've explained that. Doing it in the hospital and clinic is a big price difference. And second, there might be an increase in frequency, but if you want the detailed figures, we can provide that. You don't have the calculations. It doesn't matter. You can provide it as an annex. So when you do the business, you have to do these calculations. Any more questions, Mr. Chan? Just these two? I had previously discussed with the Secretary. Could you give us the consultant company's risk table? The risk of claims. So for each disease, what are the probabilities of contracting the disease? For example, colon cancer, and what is the payout? That's a basic principle of insurance, and then you divide the risk. They must have these risk tables. Could you provide these figures for us? Or you just tell us it's 3,600 or 3,900. I don't know how you arrive at that figure. So do you have these figures? So when you adjust the premium, second point is, you say you've calculated the profits as well. You expect how much profit they can make. It's about 47%. So should the consultant should they also provide figures not including profit and administrative fees? That would reflect the medical costs. So with the participation of the insurance company, there are additional administrative fees. So we need to compare how much the different insurance companies charge, how much administrative fees they charge. That's response to item B. Anything else? We can revisit this when necessary. We'll move on to item C. The high-risk pool. How did you arrive at 4.3 billion? And if you change the age, item C, That's in Annex B. Any questions? The first question. The government administration has said in the media that over 20 odd years they'll be spending $2 billion, and I don't want that they're subsidizing the insurance companies. The $2 billion, if it's not worth it, then would the government consider doing it itself rather than have the insurers handle the high-risk pool? We don't want the government to say that they're subsidizing the insurance companies. The $2 billion sounds like a lot, but in fact, this is not money made by the insurance company. The 12.5% is a very small figure. So will the administration consider handling high-risk pool themselves? And second, your cutoff point is 40 years old. If you look at Table 3, for different ages, the subsidy is different. So even at 50 years, the government is only paying an extra $5 billion. So unless you set it at 65, where it would cost an extra $10 billion, so the government should consider 50 to 55, because if you're at 40, that's when their burden is the heaviest. They have to pay mortgage, education, but between 50 and 55, they are more. They are at a more. They have more disposable income, so they can consider joining the high-risk pool between the ages of 50 and 55. And 4 or 5 billion is just 10% of expenditure, so the government should not be so mean.
If you are just to do one thing, then you should raise the cutoff line to 50 or 55. The Permanent Secretary, the $2 billion are not to subsidize the insurance companies. There must be an administration cost to doing anything. The $2 billion are administrative costs. If we are to do it, then this is administration cost we have to bear. I beg pardon. And if we give it to the private sector, that's roughly the amounts that we will give to the insurance companies. This is our calculation. Whoever is to do it, one has to pay the administration cost. Now, that's a fair comment. Otherwise, people say that insurance companies are making the profit. We've already said it's administration cost, and we've never said that it is to subsidize insurance companies, and the newspapers should have known that. It's very important to clarify this. This is just the administration cost. As for cutting off at 50 instead, you have to consider the operational aspect. Insurance companies want the pool to be bigger, and people join the pool earlier. When there are more healthy people, relatively speaking, the risk will be lower. We can clarify this. We will explain why the cutoff point is at 40. If the public is of the view that the cutoff age should be higher, then the financial implication should also be considered, and whether such financial consideration or implication should be accepted. The $4.3 billion, you put it in Table 1 as to show how you come up with it. And then you also mentioned the different ages in Table 3. Table 3, 45, 50, so on and so forth. Shouldn't you also provide the table for ages 45, 50, 55, so on and so forth? The cost is increased because of the items cover. Say, for example, cost of claims will be higher. Total cost to operate will be higher. With these changes, the overall cost increased. Overall cost increases. You also mentioned the high-risk pool. How many will be in the high-risk pool? And basing on this calculation from 2016 to 2040, in fact, they are being cut gradually. They will certainly gradually disappear. So can you provide a complete table? When you consult the public, then the public can comment. I share the view of Mr. Chen. I prefer to have the cutoff age older. Some may have taken out insurance, but sometime later they stopped paying insurance because of their financial conditions. It's not that they are greedy or they are young, they don't want to buy. They may not be able to buy because they have a financial issue to deal with. Say, for example, there is, say, at the age of 37, there is an economic downturn. A lot of people are out of jobs. Then they cannot pay the insurance. And then after 3 years, when the economy bounces back, they are all beyond the age of 40. And therefore, they will not be covered, according to your scenario. Any more questions, members, on item C? If not, then we will move on. Is there item D? Oh, yes. Assuming that the cutoff point is at 40 years old, can those who do not comply with the minimum requirement, i.e., the agreements between the insurers and the insured, they will not be covered. What are the comments from members? Mr. Chen, now you say that in 2013, 161 cases were closed, 50 were about excluded items. But do you know how many claims were there? In Hong Kong, I believe, there were hundreds, more than 100,000 of them. So 50 cases were just 0.0000 point something. In the first year, pre-existing conditions will not be claims pertaining to pre-existing conditions will not be entertained, but subsequently these pre-existing conditions will be covered. And please do not quote examples to show that to show us in a bad light. Well, in fact, there are many claims. The denominator is hundreds of thousands. Otherwise, people wouldn't have taken out medical insurance. If the cutoff point was 40, can they be allowed to take out part of the cover? I think the administration should not interfere with the current medical insurance market. If you do not meet the minimum requirement, you are not allowed to buy these insurance products. Either you pay more to buy a medical insurance that has a greater coverage, or you do not have any coverage. It's all or none. Why can't you allow people, say, to choose? Say, I'm able to buy only that amount, and then I'm allowed to do so. It seems that you just like the monster parents. Either you buy this, or you don't buy. Just all or none. Why don't you allow people a choice? Say, I have a pre-existing condition. I have heart disease. But, okay, no cover for my heart disease. But if I pay, can I be covered in terms of kidney disease or other diseases? Why you try to paint them into a corner? Either it is a all or none scenario. Hong Kong is a free economy. Why don't you allow people to have a choice? The chairman has just described a scenario. People want to have a choice. People want to, say, take out a partial cover. The most important thing is whether it's a fair deal or not. It's not that you give full premium, that you just given a partial coverage. If you give a partial premium, then you have a partial coverage. People enter into the agreement with all eyes open. The administration should think twice about it and shouldn't ram it through. We've exchanged our views on this on many occasions before. Concerning the accusation that we are monster parents, well, if that's the case, and we are not the first one, they are all monster parents. All countries are monster parents in free market economies such as Australia or Singapore. A long time ago, they started with this requirement. There must be a reason for this, and the reason is not monster. Medical insurance is different from other kinds of insurance. Say travel insurance. I go for a trip, I take out the insurance. And next time I go, I take out another insurance. There is no change in risk. But for medical insurance, when I bought it at the age of 20, it was very low and can renew that easily. Next, after a few years, say if I want to have a bigger coverage, then I may have to get the risk to be rewritten. And because you may have hypertension or may have other illnesses, the risk becomes higher. There is basic requirement. It's not that they limit it to one product. Just like any other consumer products, there are basic requirements which are related to safety. Same for telecommunications. Say you cannot say you pay for a cheaper plan and you can only get through 5 out of 10 calls. That cannot be allowed. We must require them to be able to get through all the time when you dial the phone. When you same for insurance. If one is to buy medical insurance, we have to consider what is the basic coverage, and we've agreed that it is to protect the citizens, encourage people to have a choice. When they fall ill, they can have the private sector hospitals. Then they must have this basic requirement, say hospitalization, at least $500 of coverage. Instead of just paying you $500 simply for a lower premium. Or say, for example, cancer. I think chemotherapy is very important. If you just buy surgical insurance and don't have chemotherapy coverage, then that's a problem. I think the issue or the bone of contention is whether there can be permanent renewal. This is the minimum requirement. If I can buy some products which are cheaper by, say, 20 or 30%, but if there is no renewal guaranteed, then after a few years, it is found that the person has a problem and he cannot be renewed. His policy cannot be renewed. The bone of contention is here. Should we have a consensus concerning medical insurance in Hong Kong? What are the basic requirements? It is not limiting to one product only. Mr. Chen Kim-ho. Chairman, we have discussed it many times before, but let me reiterate. It's all right with the administration starting point. You think this standard is the best protection to the citizens? I fully agree with that. That's why we have been talking to you with that, and we have this product. But as I said before, this is good, and this, because it is good, is costly. The cost may be -5 to plus 45%. We leave it to the people to decide. Your problem is that you have this, you can put it on the shelf and let people pick and choose. Why you stop people buying other products? Just like selling cigarettes, you still allow people to sell cigarettes, though they're harmful to health. Now the product is costs 3,000 something to 5,000 something. Why don't you allow me to buy something cheaper? That's really unreasonable. Concerning the good things you mentioned, I really want to do it, but it's too costly for some people, and they are not able to afford that. We don't just sit there and wait for doomsday. We are working together. We try to find a suitable plan. Now we are trying to standardize the plans, and we give more choice to people. Now I have the government product at this price, but I also hope that you can give people a chance. Say the insurance company will not have this part cover or that part cover, but they have to be spelled out very clearly. If you think pre-existing condition is very important, we get a product covering that. If you keep making claims and you don't allow insurance companies to increase the premium, then individually, then let us raise premium together. We have these products, but they are costly. And if you have limited money and you want certain coverage of certain conditions, and why don't they be allowed to do so? If the employers want to provide a certain cover, why don't you allow them to do so? I've been talking about it, but it seems that the message can't get through. People's choice is very important. Do not try to ram it through and try to brush aside market forces. Now, without your intervention, every year there are 100,000 or so new insurance policies. If there is a problem, why are so many people taking out new insurance policies? Don't keep saying, don't keep repeating the same thing to me. Please accept our views.
Simple response. We have been in discussion with the industry. You are talking about cheap products, $1,000. We would like to know what you're selling. We'd like to see what it covers. And second, you mentioned some employers. Some employers have provided some insurance and they feel it's insufficient and they want to purchase more. We're thinking about that. We're not trying to steer you towards a certain product. We hope that an individual, they have limited knowledge of insurance. If they want to purchase medical insurance, how can they purchase something that has sufficient coverage for them? And they also need to know what they're purchasing. And when they purchase a product and they can use it, that is when they're ill, they have a choice of public or private Medicare. Hong Kong is different from the U.S. It's totally private in the U.S. So their products are very expensive because insurance includes flu, traffic accident, liver transplant, target drugs, so it's very expensive. But Hong Kong is different. We provide the emergency service by the HA, and for complex cases, the public sector will not deny you service. So if the member of the public wishes to purchase insurance, then for simple procedures they can choose private sector Medicare, because a lot of consumers find that their insurance coverage is not sufficient and they have to return to the public sector. So you also talked about the employer's contribution. If the employer contribution is insufficient and they want to top up their coverage, this is something we can look at. Your example, you talked about if if you can get full coverage at 3,000, then 1,500 you'll only get half. You mentioned that Hong Kong has a different heritage. The public sector coverage is different. So you also frequently say that the public pays a lot of taxes. You cannot deny them of this service. And the public sector is a safety net. That also affects behavior. If they purchase insurance, they will look at the best service. But you need to understand, Hong Kong consumers are very smart. They won't pay and not use and not continue to purchase the product. I'm happy to hear you say that you are aware that employer contributions are not enough and you're willing to explore the possibility of allowing them to extend coverage. I see a lot of patients. They have insurance, and ultimately they go back to the public sector. The government, if you want us to support your stance, then will you do some surveys? Will you look at the coverage for the premium paid and provide some statistics? Because Mr. Chan is saying allow the free market, but we have some cheap insurance products, and ultimately the patients go back to the public sector because the insurance doesn't offer the sufficient service. And you also need to conduct a survey with the insurance industry. You need to build consensus on the methodology. Otherwise, they will highlight the shortfalls in your methodology. You can do it together with them, because the controversy, let's say you allow claims of 58,000 for cancer patients, and the premium you set it at 29,000. Well, put simply, you can have premiums at half the price. It's half. You allow them to claim, that will determine the premium, just multiplied by the same coefficient. I just assume that. It's not necessarily the case. So you can demonstrate to the public that when you have no minimum threshold, you only allow them to claim 20,000. It's useless. If you are willing to use the private sector, they won't bother to claim 20,000. So some insurance products, you have to show the minimum threshold, because there's a difference in claims. That's first point. The second calculation you need to demonstrate is after the price increase, where the minimum requirements are met, let's say 45%. So after the price increase, less people will purchase the product, and whether there are less consumers will depend on sustainability. Sometimes we have vicious competition where there's price cutting. So if your study indicates as there won't be less customers after a price increase, then the industry won't criticize you. They're just concerned that after price increases, nobody will purchase cheap products and they will do less business. But if they maintain the same business turnover, the insurance companies won't complain. The basic requirement of sometimes it's price, room and board, for example. We want, let's say, a reduction of 600. It's now 400-500. So it's not a big problem because we already making reference to the industry trends. But for continuous coverage, when you purchase the product, you don't know the outcome until 5-7 years later when you make the first claim. The next year they add your loading or they don't insure you, then you'll know. So a lot of people don't know what the impact is, and let's say after the price increase, we won't necessarily have less customers. A lot of items are not included: day surgery, MRIs, CT. I'm working in the market. The operation or medication, it's included. Some insurance packages don't cover that. You only see patients that have these covered. So I'll have it done inpatient, so the cost will go up. So colonoscopy, some companies already allow day surgery to do colonoscopy, but some don't allow that. So when we have the minimum requirement, when it's standardized, then the whole industry will follow. And of course, we can attempt what you mentioned. We can examine the price impact on the market. So if the insurance companies have cheap products, let's say 100,000 clients, and after the price increase, they still do 100,000. They still have 100,000 clients. There's no loss. They're concerned that after price increase, they will have 30,000 less clients. It's not just the insurance companies. They have different products. They have different profit margins. They look at profit margins and push the products. We have low coverage, and the profit margins might be higher, but there's no continuous coverage, and they have to go. They cannot claim it at the private sector. So that's the reason where they resist these products. We can look at your suggestions and provide more data. Any other questions on item D? You feel that coverage is insufficient? I hope that when they can also, the industry can also provide some data for us. Well, I believe you will consult the public, where the public can have more choice. Item D. And is there an item E? We can revisit this when you think of a question. Next item, the manpower planning. So the university already has a report? No. This is just a preliminary. We had explained the basic concept of their model. Chairman, you wanted an update on their assumptions and parameters. So on this occasion, we have Professor Dr. Zhao Jigin. So after building the mathematical model, we're now collecting data to run some of the figures. So if Chairman allows, I'd like to defer to Dr. Zhao to explain this computer mathematical model. Dr. Zhao?
主席你好，我係周。
Good afternoon. I'm Dr. Chow. I'm here to explain to you the healthcare manpower model for the Bureau. After constructing this model, the administration can make use of the model to estimate the demand and supply of 13 healthcare professions. The model is made of two parts, the supply part and the demand part. The two, one minus the other, will come up with the conclusion whether each health profession needs to increase or reduce its manpower. First, on the establishment of the model. The issue is whether it's a multi-equation model or single equation model, so as to establish the interaction of the various variants within the model. Modeling is restricted by two constraints. Number one, the nature of the system, and number two, the data available to us so that we can do the modeling within the system. Systems that are difficult to be explained by physical phenomena will have a lot of variances, and we adopt a curve-fitting approach to do modeling. Curve fitting can be regarded as just playing a badminton. Your opponent hit the ball, shuttlecock, towards you, and you can estimate the track of the shuttlecock. And that's roughly what's meant by shuttlecock, or rather curve fitting. And if we use curve fitting, then we are very much dependent on the data available. And to build a good model, we need, or rather, the quality of the model is proportional to the number of variances. If there are two variables, then we may say, let's say, build a model with 10 points. But if we have three variables, then we may need 100 points, so on and so forth. Therefore, we have to make choices. Data are passive. And we have to work on the data available to us, or data in our hands. Now we have to make use of all the variables. Or should we use all the variables to describe the model, or should we just pick some variables such that we can use less data to do the modeling? We have to make a choice. That is some trade-off here. With regard to system modeling, there are two kinds of approximation. Among so many variables, what are the major variables for modeling? And number two, what equations do we adopt to model the relationship between the variables? The approximation or the model is just an approximation of the system. You are not able to use the model to accurately know at a particular point in time, in a particular place, the model is, what the model is. The healthcare system in Hong Kong is very complicated, and we can only adopt a curve-fitting approach to do the modeling. With these constraints, we need to have a core assumption. We have to assume that the future trend is related to the historical trend. If, say, the future is a random outcome, then not a single model can be viable. And we have to base on the assumption I said earlier. That is, the future is related to the past. We have 13 we have 13 models, or rather, we have one model for each of the healthcare professions. Altogether, there are 13 professions, and we have to make suitable adjustments from one model to another. Now, today we use the demand supply, or rather the doctor demand model as an illustration of the macro mechanism. In the doctor demand model for doctors, we link it to the types of service, the quantity of service. There are 13 kinds of healthcare services. We have also categorization between public and private, and then inpatient and outpatient. And as for inpatient, we consider the discharge rate, the number of days of staying, or bed days. As for outpatients, we consider how many GOP, how many SOP, and then how many E&E case, how many visits under the DH, conducted by the DH or the HA. As for private sector, we do the same, say, number of discharge, day of the bed days. We have the healthcare utilization of the 13 kinds, and then we turn the quantity into the number of doctors required. First of all, we have to consider the utilization, each utilization. Say, for example, discharge, bed days, outpatient, how much time is required of a doctor per case. Say, for example, for a discharge case, you need X number of doctor days, and then you have Y so many discharges, then you need Y number of doctors. And then if you add them together, then we will come up with the number for the doctor required in the next year. I have to apologize that the equation here, we have discovered that it's a typo. It should be inpatient rather than day case here. As for this equation, the one above is the total number of discharge. We have inpatient discharge, day case, discharge, long stay discharge. We assume that the doctor time required is the same, and we add the three categories together, and we come up with C. That is the number of doctors required per discharge. And then we have the number of bed days times the number of doctors, and then we come up with the demand for doctors in the inpatient setting. Together with SOPD, GOPD, and A&E, we can come out. We can come up with the number of doctors required by the hospital authority. The D of H, as for the D of H, we will do the same. We look at the number of, we add all the cases together, times the number of doctors required. No more than we divide the 6 types of we divide the service as 6 types. As for methadone clinic, we use a clinic base. There are 20 methadone centers, and we assume that with regard to methadone service, we need so many doctors. We need 20 doctors, and we therefore take away the methadone cases in the calculation. After having the model, we then find out how many doctors needed for one case. Say for one discharge, there is a doctor, and for the other discharge, 2 doctors are needed. There will be a big difference. We have to find ways to set the coefficients. We compare the historical data, and then we tune the coefficients such that the backward projection from 2005 to 2010 and we compare the doctors, the projected doctor in that period and the actual number in that period, and then we find out the smallest coefficient. For inpatient and for SOP, that's how we come up with the coefficients. As for GOP, it's simpler. Doctors only look at GOP. As for SOP, and also as for resident doctors, they have to take care of inpatient and SOP patient. From 2005 to 2011, we look at the case required by the doctor required by a case, and then same for A&E. As for outpatient service by the DH, we will adopt the coefficient of the HA for outpatient service. As for private hospital, or as for the private sector, the methodology is the same as that of the HA, and that is the doctors required for each discharge, the doctors required for each bed day, the doctors required for each outpatient case. We add them all together, and then we will have the number of doctors required by the private sector. And the coefficient is also done by a backward projection, and then we come up with the estimate by backward projection and then the actual number, and then we get the smallest coefficient in order that is the coefficient that yields the smallest discrepancy. We then add them all together to get the demand. How we do that projection? The Hong Kong U, being a consultant, has tried various means. Instead of considering just as one single method, we need to consider the accuracy of different methods. Say international literature may say this approach may not be good for that use. But as a consultant, we have to look at the various possibilities. We consider different approaches. Say, if you can see from this figure, we have considered using AI, artificial intelligence. We use standard statistical methods such as regression-based method, and we also adopt time series. People claim that they use time series analysis. There are also macroeconomic approaches. We test them out and find the best one instead of we just choose one and then ignore every other. We ignore all the other. So we go through all these possibilities. We want to estimate the demand for 2014. Well, the demand for service, of course, is closely related to Hong Kong's population. The elderly will have a higher usage rate in comparison with the young. After 10 years, the number of elderly may rise to 1/3 of the population, and by then, you don't need to consider things. You just look at the change in population structure, and there you know certainly that there is a change. We also need to project the utilization rate. And then after we've got the utilization rate, then we multiply it with the Hong Kong population, and then we will come up with the total utilization. Let me now explain to you the 6 models which we have considered.
The first being the support vector machine. It is part of a neural network theory. You can imagine a neural network as a group of brain cells, or each small unit has very limited function, but by connecting with other brain cells, the overall power is much larger. The neural network uses a similar concept to model nature. And the first neural network was introduced in 1943, and by 1960, because of a mathematical breakthrough, the communication power of a neural network was increased, and we now have pattern recognition and imaging processing based on these neural network models. It sounds very powerful, but you need to know how many neurons you have in the neural network, and you also need to know how they connect with each other to maximize the computational power. But until 1995, there hasn't been a lot of progress. Everybody was just guessing. And up till 1995, scientists developed a support vector machine. So through a series of calculations, we can calculate how many units neurons are needed, how they should connect to maximize power. Because of this nature, in AI we use the SVM. And we use our Poisson regression in statistics. We take a straight line and apply it in this case. And we assume the utilization rate belongs to a certain pattern in the distribution. And the third approach is the time series approach. You assume the stock market, use the past performance of the Hang Seng Index to forecast future trends, and we use these 3 models. We use the linear trend. In 01, we have elderly using the hospital once, in 02 using it twice, in 03 3 times, so in 04 4 times, and 05 5 times. And the decay trend is like when you purchase a car, it's worth 1 million, and with every subsequent year there's a 10% discount in value. And the third one is a constant trend. The utilization is not related to the time, but the utilization rate is constant, even if it's constant. But this will still change according to the change in population demographics. D, E, and F can be categorized as an economic approach. So we have average inflation of 5%. So these three approaches differ in how we estimate the growth rate. D is constant growth rate, where we make reference to international literature, and after discussion we find that public sector has 0.2% growth rate and private sector has 1% growth rate. And historical growth rate is very local. We look at Hong Kong history and estimate the growth rate. In D and E, there's no limit. It's like compound interest. In 10 years' time, it can increase significantly, unreasonably high. So we decided to try another one with a capped growth rate, and we cannot use the calculation in D and E. We have to estimate at what year it will cap. So we have a total of 6 methods, and ultimately we have to choose one model for projection. So first of all, in implementation, we found that some were realistic. The regression-based model is similar to D and E. It increases indefinitely, so we need to give it a cap rate. It's a very subjective figure. You cannot find an objective figure. And we're not talking about one capped rate. We have 13 capped rates, and you cannot identify and debate over each of them. So we forego the regression-based method. The second one is the capped growth rate. Theoretically, that should be better than D and E, but we don't have sufficient data to find the parameters in the sigma function. And maybe after 5 or 6 years, when we have more data, this might be a choice, but at this point we need to forego this approach because we can't find the data. And the last one is the Anderson model. This is a very famous model in the healthcare system. It considers that age, demographics, smokers, behavior risk factors, how many people purchase insurance, everything that you imagine can be included. But our projection is for 2014. We don't know how many smokers there are and how many people purchase insurance, the average income, we have no idea. So we will also forego the Anderson model. So lastly, we are left with SVM and 2 economic approaches, the historical growth rate and the economic approach. So SVM beats all the other methods. That was that was predicted. But we also decided to provide other figures to defend our position. And it was very obvious that SVM was better than the two other approaches. So that's why we adopted the SVM model. So after the demand model, we'll talk about the supply model. I think we have explained this once. So the supply model, you can model that on physical phenomena. The stock and flow model, you can imagine that as a tank on the top of a building, and the buildings will use the stored water at a supply at a constant rate. You can predict. There's heavy usage in the morning and heavy usage at night. You can predict that. But we have constant inflow, constant outflow, and you need to maintain. If you want to maintain water supply, you need to add a buffer. So that is the stock and flow principle. It's like the doctor supply model. We have new graduates every year from 2 universities, around 400 new doctors, and non-locals, some 60 entering the system. At the same time, we have doctors not renewing their licenses, people dying, people leaving Hong Kong. So we have the inflow graduates and the outflow. So that's why we use the stock and flow model. We have some doctors working 24 hours a day. So in fact, every year we have an equation to look at the number of doctors available. We look at the number of doctors last year. We look at license renewal, and we add local graduates and non-local graduates. But in fact, not every registered doctor will practice according to the health department survey. Some people will register but not practice. They might be retired, or for whatever reason. They are registered but are in other professions. We have to take that into account. So we can't say we have 100 doctors and have all 100 of them in and all 100 practicing. So we have an active proportion. So out of the number of doctors, how many are actually practicing? Let's say we have 100 active doctors, and we have to convert that to full-time equivalents, because that means how many hours you are available. So younger doctors might work longer hours. Senior doctors might work less. So you cannot. So we need to standardize all the ACS doctors on average, how many years, how many hours they can practice, divided by standard working hours. That gives you the supply. So when we have the supply and demand, we can calculate the difference and see how many more or less doctors we need, and how we can balance the equation. So let's say starting from 2015 we are short 100 doctors. So starting from 2015 we need to add doctors to balance the equation. So we use the gap analysis to provide policy guidance to the government. So roughly that's my report.
嗱，問題就有好多嘅，不過俾議員同僚問下先，有冇問題？陳健波議員先。
係我想問喺
Yes, question from members. Mr. Chen Kim-po, have you considered the increase in the beds in private hospitals as a demand indicator? Now, if the number of beds is increased by 2,000, it will be very different from increasing the number by 4,000 beds, and that will have a serious implication on the number of doctors. That's on demand side. As for supply side, I see a number. Non-local graduates. Many non-local graduates cannot practice in Hong Kong. In the future, if there is a change in government policy, say, the licensing examination becomes more relaxed, then the supply, that will have an important bearing on the supply. Have you taken that into account? Say, Chairman, in the increase in number of beds. This is an externality. We take it as an externality. That's a top-up arrangement. That is, I would consider the implication. But do you know your basis? Say, is it based on government projection or what? 2,000 beds? You base it on this number. If there are more private hospitals, then the administration will have to revise this number. So your basis is 2,000 beds, right? Mr. Chen is right. An important model is an important aspect is there are many variables, and we need to know the assumptions of these variables. The member is right. We know the number of new hospital beds or additional hospital beds, and then next year when the situation changes, then we can refine the model. We can keep refining the model. As for non-local graduates, how do you deal with them? We are not talking about the number of graduates practicing in Hong Kong, but the number of non-local graduates who are admitted to practice in Hong Kong. But have you considered the substantial increase in the number of non-local graduates with a change in government policy? Mr. Chen is right. There are 2 licensing examinations instead of 1 per year, and they also adopt more modern type of examination that will attract more overseas graduates to sit for the licensing practice examination. Yet we still have to maintain the standard. The model they've adopted is based on previous experience, about 20, 30 local and non-local graduates per year. When the model is concluded, there may be a change in policy and there may be a gap. And we try to deal with that. This year, the number may be increased to 40 or 50. In the future, there will be recommendations to narrow down the gap. If there is a big gap, then we have to consider measures to narrow down the gap, and we can focus our attention on specific aspects of the model. Now, this is a long-term gap. We can do it with local graduates, and we can do it with some other means. Dr. Joseph Lee. I have several questions. Thank you very much for your lecture. You have ample time. Now, this is a utilization-based model. In your PowerPoint, you say you depend on the historical trend. Well, it depends on history. The coefficient is also important. That is a benchmark reference in your demand model. How long is the history? Past 50 years or past 30 years? 2005 to 2011. Sorry, 2011. What is the justification for just choosing 2005 to 2011? You assume, I don't challenge the technical aspect. You don't have the data. You only look at the period from 2005 to 2011. So what you put, input, gives rise to output. Why don't you go back from 1997, or why don't you go back to 2003? Are data not available? I'm also an academic like you. The longer the history, which is used as a basis for your modeling, the more accurate the model will be. I don't challenge the model, but if the coefficient is so important and you base your assumption on historical trend, and then if you just look at 6 years in the past, I have some doubts about it. I'm not criticizing you. I'm just telling the government. Your coefficient is your coefficients are very important. They are important benchmarks. Now you adopt the activity-based approach. Mr. Chen asked the increase in number of beds. Now with more hospital beds, there will be the increase in number of discharge, and then that will lead to 100 more things. I understand that when the administration explain to the professions, please highlight this point. As for us, it may be just a few more beds, but for you, it will turn into the number of discharges and then implications on doctors and other professions. I don't argue whether the SVM is the best model or best approach. I still have a question for the consultant. Why you are not able to use the Anderson approach with regard to projection? Is it that you don't have enough money, or you don't have enough data? The administration has capped the expenditure. If you adopt the Anderson model, will it be more adequate? In the healthcare profession, it is regarded as the most comprehensive model, but you don't use it. You need to explain that. I'm not asking you to explain it here. I don't say the SVM is not good, but the Anderson model is better. Is it that you don't have enough data, or is it that it is unpredictable, or what? You need to explain that. I might have fallen asleep in the middle. I didn't catch the point between linking up the demand and supply. In your utilization-based model, do you work out the demand first, and how do you link up with the supply, or the two don't link up? Now we see this is the demand, and this is the supply. If you draw a concept map, there must be dotted lines, solid. There must be dotted lines, solid lines, arrows to achieve a balanced model. I might have fallen asleep and I missed this point. Just two questions. First, the coefficient is important. I just want to know why it's just 2005 to 2011. And the second question is on the link up of the demand supply. Yes, doctor? Why we adopt the data of 2005 to 2011? There are several reasons. The HA gave us the data from 2004 to 2011. They only started to have electronic data from 2004. 2004, there was still the post-SARS effect. If we put the year 2004, then we would have told the SVM that there might be a SARS again in the future. That's something we want to exclude. You ask whether the longer the data, the better. If you start from 1997, then the HA, the hospital system is changing, and different health professions have to deal with different kinds of workload. And the more years you added, you confuse the scenario. Say, for example, before 2004, as for nurses, as for the nursing profession, there was no health worker. If you use data before 2004 and you estimate the nurses, then that may not be adequate. Well, I think he will have a problem. He will get into trouble with that. Now, before 2004, there was no such post, and nurses have to handle certain workload in this regard. After 2004, nurses didn't have to handle certain workload in this regard. That's why we choose 2005, because we have excluded the post-SARS implications, and there are health workers helping out. That's why we use 2005 as starting point. We stop at 2011 because the project started at 2012. If we have to edit every year, then in 2003 we'll have to refine it until 2012, and in 2014 we'll refine it to 2013. We keep on refining the numbers. That will not be efficient. I think it's better for us to get the latest data one-off when we submit our work. As for the Anderson model, I agree that it is better. It covers more variables or aspects, but when you do the projection, you need this set of variables or the projections of these of this set of variables, and that is not possible until 2041.
至於你話 demand 同 supply 嘅話就我哋一方面 independent 嘅有 demand 啦。
We calculate the demand independently. We calculate the demand, the supply independently, and that is a gap. And this is the gap analysis, and we link the two together, and that is a gap. And that's the gap analysis. As for historical data, as said by the doctor, if you do linear projection, it's very effective, but there are many historical features built in. In 2004, there was the SARS effect. And if you took those data, such effects would be incorporated into the model. And our concern is the coming rise in demand. Say, private hospitals have been expanding, more and more people using private hospitals. There is the issue of population aging. If you project backwards into the 70s or 60s, there is no such problem. And this will only dilute the effect. We therefore have adopted a nearer time frame. We can see quite a significant aging population, and therefore we will be able, we hope that we can have a better projection. The neural network is able to take care of this, and that is the implication of aging population demand for healthcare manpower. That's a better assumption. As for gap analysis, it is just to tell us the gap and it's our responsibility to bridge the gap. We'll look at the data and we'll find them reasonable. We run various models. We will run it several times. Say, for example, this is a supply. The demand may be like this. There's a gap. You can see the gap. And when you see the gap, then we'll consider models, as said by Mr. Chen. How can we fill the gap by, say, increasing the places in university? And also, as for the HA, the retirees, how can we make use of retirees? If we can't add manpower very quickly, can we use the excess manpower in the private sector or excess capacity in the private sector, and also licensing, examinations, so on and so forth? We need different methods to deal with the gap, and we can form a basis for discussion. Now we say, it is not enough. Some say it is enough. Some say liberalization. Some say not. There is no basis for discussion. They need to show the gap to us. That's their responsibility.
李國麟議員等等先，因為張國柱議員都排緊隊。
我簡單跟住，因為佢哋有講過嘢，唔好意思啊，我哋仲有時間得2個人坐喺度嘅啫，係仲有其他。咁咧就因為你就係講個 coefficient， 我明白嗰個，即係我唔係 challenge 你因為而家未有數睇噶嘛。不過即係我想呢樣嘢係政府解嘅，當時整出嚟你要解翻嗰個即係0至1嗰個係一個好重要嘅，因為個 coefficient really matter。即係你唔解嗰個，你擺咩落去？我都話即係多謝你個 machinery。即係呢個 machinery 做咗之後咧，擺咩落去就擺咩落去㗎啦。咁就對唔住啊，唔係你擺落去嘅，係佢擺落去。咁即係呢個解得通。咁但係有個 point 我想 mind 去澄清翻咧，其實咧你所講嘅 HCA 咧就唔係2000年先有嘅 ，before that 已經有㗎啦。咁嗰個咧即係但嗰個反映咗一樣嘢就係、即係如果政府特登拎有某個時段唔擺落去嘅嘢咧，就會我唔係陰謀論啊，不過我係講事實，即係你因為呢啲原因你唔拎呢啲時段擺落去咧，出咗啲唔同嘅嘢。咁呢個喺解話時解埋。唔係一定好多 challenge 嘅，係一定我同你嘅意見唔同㗎。我話應該佢擺唔擺都有影響，你話冇擺落去，咁即係個 machinery 喺度。不過即係副處長你睇到你明白我講咩㗎啦嚇？咁就我講完啦。
近少少咧就更加突顯到人口老化個影響。
咁啊多謝周上咗我一堂啊，多謝你啊。
好，張國柱議員。
係多謝主席，我就唔係專家又唔係學者，我係用家。剛才就係 project 呢個醫生嘅，咁我估你都會 project 埋輔助醫療人員啦。咁輔助醫療人員，我諗醫生係簡單啲，但係輔助醫療人員咧就即係福利界都用，同埋我真係我都唔知點估嘅。原因就係佢可以用護士，但又可以用2個嘅 health worker 代替一個護士，啊！即係啲法例係咁寫啦，咁所以咧就呢個第一，第二咧就係我哋都用好多 OTPT 嘅，但係可能即係同醫管局嗰邊即係競爭咧，我哋永遠都係二奶嘅，咁所以你係點樣將嗰個 demand 擺埋落去你條 equation 嗰度咧？咁就剛才提即係嗱。福利界咧，除咗係長者同埋殘疾嗰邊用多啲輔助醫療人員咧，長者又分呢個社區照顧啦，同埋院舍啦。院舍我哋而家又有呢個CNA home 或者係 infirm 啊嗰啲咁樣，即係慢慢係會即係嗰啲輔助啲醫療人員係要增加落去，同埋佢唔同時段開唔同嘅院舍咧。
We need to have, as long as we have money, we can increase these posts. We're now talking about community care, therefore they need more community care centers. They also have home visit OTPT. So it's very hard to estimate. Just now the Secretary also mentioned aging, because we'll have more elderly and we'll also need more welfare services for the elderly. I also want to mention that this should be the outpatient doctor numbers, but we also need specialists. It includes specialists. And just now, did you mention when the projection will end? 2041. So that would be the peak of our aging society. Will you project a further 25 years? I'm afraid that you continue to increase. First of all, regarding nurses, the forecast for nurses. So we work together with the Social Welfare Department, and this model, all the parameters are included, all the assumptions are in place, and then we have externalities, who we capture known development and policy development. You mentioned new community care, or we have new policies, community care vouchers. So we're working with Social Welfare Department, and they will provide us with some data. Regarding nurses forecasts, it's mostly with the HA. They have some 20,000 nurses in the HA system. It doesn't have a large impact. We are aware, and we will consider that as well. OTPT, that's different from nurses. The demand is very large in the private sector, and in the private market, you said they are second rate, but that's the opposite case. In fact, we have a large shortage of occupation therapists and physiotherapists. So we will work with the Welfare Department to look at the latest trends and consider the market factors. The third, the range of the projection will run to 2041. It won't be 100% accurate, but you want to look at the long-term trend, and they will be accurate in the coming 8 years, and afterwards it's just a trend. The important aspect of the model is that every year or two we update and fine-tune the model. And why do we start with doctors? Because if we can do a gap analysis, and when we need to fill the gap, it takes a longer time. If you're talking about specialist doctors, it takes 10 years. It's a long turnaround time. So their forecast needs to be longer. For others, it's simpler. You can fill the gap in 2 or 3 years. So that's why it runs 2041. But we need to fine-tune it at a regular interval. Anything to add, Dr. Chow? Just now the Secretary referred to OTPT. That's true. In the private sector, the demand is very large. We cannot use existing government subventions or NGO projections because there are new demands of autistic children. We don't have these services, but the demand is very large, and the therapists are already moving towards that sector. OTPT, we have not started because we want to start with doctors, nurses, dentists, to do a test run and to see empirically before we run the actual model, and then we can look at other sectors such as OTPT and healthcare assistance. I'm a doctor as well. I understand these. We have different models, and you project 05 to 2011, and the recent years are most relevant to existing times, and the drawback is you have less data. I understand that. Each model has its strengths and weakness. The neural network, I understand that as well. So, as an academic, I don't think you have much political considerations, but in reality, in the healthcare system, there are some issues that cannot be included in the projection, and I think that that has to be dealt with by the government. For example, why you didn't include the SARS year? Was the utilization high or low? Do you think it was higher or lower? Lower, why? Because the hospitals were closed. The patients didn't go to hospital. So there's some patients, they didn't even need to be examined. So the higher the supply, we have a supply-induced demand, and there's a higher utilization. So in the government, when the funding drops, the utilization rate drops. Because when the funding drops, they recruit less, the waiting list becomes much longer. The people in the waiting list will disappear, they don't want to wait. So if the funding drops, the utilization rate drops. And recently the financial secretary said if health funding increases 7%, 4% is population growth, 3% is actual growth, then in 7 years we'll be in the red. So he's saying it won't grow after 7 years. So what do you predict in the coming 6 years? It might be correct, because but afterwards there's no more funding. You're not the financial secretary. I'm not going to ask you that. I just want to ask the secretary. So aside from projections, do you have an algorithm when you discover there's a gap between supply and demand? How will you adjust your algorithm? There's always time lag, and will you consider funding fluctuations, utilization fluctuation, and the private market supply elasticity? The private market is not short of manpower. The more they work, the more they earn. So how can the government balance funding, utilization, funding elasticity, and private market manpower supply elasticity? How would you consider these in your algorithm? So you've done the projection. There will be some errors. We can accept that. But any model, how would you deal with the things that they have not included, such as government funding? Well, Chairman, as you said, this is a projection for 7 years. So the model, the externalities are known, or things that we're quite confident will occur. Regarding the models, inherent response to reality. That's our task. So every year or 2 years, at a regular interval, we need to review the model. When we are aware of new issues such as a funding cut, these factors will be included. Can you go back and work out an algorithm? You can call it a model, I'll call it an algorithm, flowchart. How will you handle changes? Let's say the private sector can handle discrepancies. You can deploy from the private sector. Can you work out an algorithm? And what I mean is that in 2018, for example,
in 2018, suppose I see the utilization rate in the private market is very low. Many graduates will not be employed because of funding problem with the HA. When you predict this, how can you put that into the model? This is not very complicated mathematical calculation. I just want to know what are you going to deal with that. You may work out the algorithm, and I also will work out the algorithm for your consideration as well. We don't want to have not enough doctors. It seems that we run out of time. Maybe we can extend our meeting for another 15 minutes. We may not use all these 15 minutes. Another question is on distribution. Your model takes into account overall utilization. You think manpower supply is even, demand is even. When you say manpower is not adequate, I think according to your impression, you assume that there is an even shortage. But in the past 3 or 4 years, when people say manpower is not or was not enough, with regard to the 7 clusters, only Kowloon East wasn't enough. It took care of 14% of population with 10% resources. When the administration added money and manpower to the HA, the administration did not make up the shortfall. We are reviewing. Kowloon East, okay, we are reviewing it. Okay, you're reviewing it. By your model, this is a historical model. Say the waiting time is 100 weeks. You make a projection. According to that, then you have accepted this standard of 100 weeks of waiting time. Then Kowloon East, people will have to wait for 100 weeks. This is not his mistake. He has assumed that the service is evenly distributed. He cannot guess that it is unevenly distributed. Chairman, Hong Kong East, there may be a much shorter waiting time. You really don't know they divide the money in this way. Well, let me tell you how we deal with it. He showed us the objective fact, and we look at it. Now, this is a policy decision. Under these circumstances, the projection is waiting time 100 weeks, and we need to improve that. What is the reasonable waiting time? How much resources should be put into that? And then we make a decision, and then we feed it into the model, and then they run the model again, and then that come up with a number of doctors. But your model doesn't show how you deal with uneven distribution. Now you have the number of doctors that is adequate from the overall point of view. Now you base on history. You predict the future trend from history. According to your model, you will say that there should be enough doctors. But in the future, say next year, there will be 300 more doctors and will fill the gap. But when you give 300 doctors to them, there is no improvement in service. They put the 300 not in the places where most need it. Then we'll take the responsibility. Well, I go after you then. I still have to go to the meeting next door, so and no more members here. And now, when we have more questions, we will follow them up. Please provide the data. And I also want to ask you about the public consultation. When will you issue the document? Maybe June or July. That's our plan. Is it on manpower? No, HPS. He is referring to HPS. June, July. And we don't have the date of next meeting. Well, let's we will arrange that with the Secretariat. The algorithm is very important. I want to know how you deal with that. That's a feedback loop. And also how you deal with uneven distribution and also elasticity and excess capacity in the private sector, the implication of PPP. I have to go to the meeting next door, so let's stop here. Thank you.